Here are some pictures of our hospital. This is the main hospital. This is the building where we have our endoscopy, and we perform the endoscopy in the 5th floor. We conduct few courses and conferences with live endoscopy transmissions, so you are always welcome to join us if needed, and we'll be more than happy to see you in our hospital as well. So my topic today is about EUS guided CPN and CGN, celiac plexus neurolysis and celiac ganglia neurolysis. So looking back into the history of the procedure itself, it's over a year actually. This is the first article that was published by a German group in a chapter of a book talking about intraoperative celiac plexus neurolysis to reduce pain in the pancreas and the upper abdominal organs as well. So it has been a while since this procedure has been introduced. After that, other modalities looked into the celiac plexus neurolysis and ganglia as well neurolysis. And as you can see, this is a CT with a big, large needle previously going transcutaneously to block the celiac plexus and the celiac ganglia. And this is the trans-abdominal ultrasound-guided neurolysis to look into the celiac plexus and ganglia and try to either ablate, block, or neurolyze. Now, the first CPN was introduced by Douglas Fagel. He's currently a chairman in Mayo Clinic, and the first case was introduced about 25 years back when the first case was reported, and it was a successful neurolysis. Now, if you look into a comparison between the EUS CT-guided celiac plexus block for chronic pancreatitis, there's no much of literatures that look into this specifically, but this is one of the main ones. The earlier one, it's an old study that looked into around 22 patients with persistent pain due to chronic pancreatitis. They compared both modalities of block using EUS and CT scan. After 2 months, around 40% were successfully having persistent pain relief compared to 25%. And at now 24 weeks, 30% have a blockage successfully compared to 12. So probably EUS approach provided, according to this study, more persistent pain relief than the CT-guided approach. Moreover, which is expected, it was preferred technique among patients because they have a less invasive procedure and it's more cost effective as well. Now, if we ask our question, why do you have to use EUS specifically for CPN? Well, EUS CPN is safer, it's more accurate, and it's more convenient. And it can be carried out after real-time imaging and guidance of the EUS probe. You can use Doppler as well to identify the blood vessels, to look into the injectate sometimes if you are injected, if you prefer to do so. And you can assess always with color Doppler to avoid, to look into surrounding vessels as well. Now, it's worth to give a slide or two about the differences between celiac plexus block and celiac plexus neurolysis. And as you know, the celiac plexus block is for temporary reduction of pain. And we use those usually in patients who's having chronic pancreatitis, on pain medication, they're not responding well to pain medications. Then we come and we discuss with the patient that we can probably do some endoscopic intervention that can help them to reduce their pain for a while, and they might have much less pain. It's important, though, to mention to those patients that they don't expect a complete relief of pain, because from our observations, we did not see a very complete reduction except in few patients. So usually you have to repeat the procedure maybe more than once. You might not be hitting the right target. And even if you hit the ganglia itself, sometimes they can't have complete resolution of pain. For the neurolysis, we use it for chronic pancreatic, for pancreatic cancer. and it gives you more durable reduction in pain. Now, if we look to both procedure, both involve injection of pharmaceutical agents into or around the celiac plexus and ganglia, which is not always visualized. So you don't have to visualize the celiac ganglia, or you do your best, but in around 30% of patients, you can't see the celiac ganglia. So you can go anatomically in front of the celiac axis, aspirate and make sure that you don't have a blood into your needle, then inject your injectate into the celiac ganglia or to the celiac plexus. Usually it's anterior to the celiac trunk in origin. It can be left and right as well. Now, what agents we use for both techniques? Personally, I use bupivacaine as an anesthetic for celiac block, then triamcinolone as an anti-inflammatory for patients with chronic pancreatitis. I do usually give prophylactic antibiotics for block because I'm using steroids, which is not always the case in patients with pancreatic cancer. For celiac neurolysis, we use bupivacaine and ethanol of 90, 80 to 100% as a neurolytic agent. And we use in our unit 98%. And personally, I don't feel any big difference between giving 98 or 100% for neurolysis in those patients. Now, what needle you have to use? There's no specification. You can use 19, 22, 25. 25 is not preferable because it takes a time to inject the injectate into the desired area. So usually I use between 19 and 22. And there are other specific needles that have holes in the side and they can inject more broadly and it can involve more area in the celiac plexus area if you want to use. But fine to use a regular FNA needle as well. Now, the most important in this is what to inform the patient and to tell him and how to prepare him for the procedure itself. So first of all, you have to ensure adequate hydration before the procedure because as we know, the risk of hypotension, peri-procedural and basically post-procedural can happen. Antibiotic prophylaxis, mainly quinolones, can be used especially for celiac block. And it's very crucial to aspirate before each injectate. Usually we use an empty 10 cc syringe and assure there is lack of entry to blood vessel. And after that, between each injectate, we have to make sure that our injectate are all into the area that we desired. So we use 3 cc sterile saline and ensure that the needle is empty from the injectate before we pull the needle into the scope. Now, the techniques of CPN are basically two, and you can see this in this slide. You can do the classical central technique, which done by most of the EUSists, where you target the base of the celiac artery. The needle in advance just very proximal to the celiac axis, and then the amount of ethanol injected is around 10 to 20 cc. For bilateral techniques is basically where you have to inject both sides of the celiac axis. So when you see the celiac axis, you just rotate clockwise till it's no longer feasible. Then you do your injectate, then you pull your needle, you go counterclockwise, and then you insert the needle again and you inject. Usually you inject 5 to 10 cc of alcohol in each side of the celiac axis. Now, this is an example of a patient who's having chronic pancreatitis, who's having pancreatic cancer. They've been in many medications that did not relieve his pain, trying to do a celiac ganglia neurolysis here. So as you can see, this is the linear echo endoscope looking into the aorta, advancing it a little bit. You can see the celiac axis coming soon into image. And it's very important to take your time, look into the celiac axis clearly. So you can see the celiac axis in this area here. Going back, trying to identify the celiac ganglia. So here is the celiac ganglia that we are planning to inject. Then you can just get whatever needle you want, preferably probably 22 or 19. And then you go, you make sure that your needle is into the celiac ganglia, and then you start injecting the desired material according to the case of the patient. So in a while, you'll see our needle is going out. Try to advance this video a little bit. So as you can see here, our needle is trying to get into the celiac axis, and as you can see, the needle tip now it's into the ganglia, and then you start to inject the material. Now, it's not very important to go exactly into the celiac ganglia because there are a few literatures that look into intraganglia injection and periganglia injection, and there was no much huge difference, interestingly. But always, if you can look it and you go into it specifically, it will be important. Now you can see the echogenic cloud that comes from the material or the injectate that we did. And by this, the procedure is ended. It's important to keep the patient for observation in a while after the procedure itself. Now, what is better, central or bilateral technique? Now, there are two probably big retrospective cohorts that looked into this. So for pain relief, the CPN was superior in the bilateral rather than the central procedure. So it was around 85%, and the central procedure was around 45%. For the pain reduction score in other study, it was 70 and 45. After that, Haddad and his group did an RCT on 50 patients to look into the difference, and they concluded that there is no difference in pain relief. It was 70% in the central approach and around 80% with no significant p-value. So I think it's a debatable. I think the best is to do whatever you feel comfortable with. You can try both techniques. You can see what you're comfortable with more and what you're used to do, and you can just do it this way. Now, for the celiac ganglia neurolysis, the position is usually between the aorta and then the left adrenal gland, and with careful linear echoendoscope, and many times you can probably see the hypoechoic connection of the ganglia, and then you try to target and inject this one. So any meta-analysis that looked into the efficacy, if we look into the literature, there is two major meta-analysis that looked into this. The first one looked into CPN for pain relief in chronic pancreatitis and in pancreatic cancer. For chronic pancreatitis, A studies with around 300 patients, and for pancreatic cancer, 400 patients. And you can see a very good rate for pain relief in patients with pancreatic cancer of around 80%, compared to around 60% in patients with chronic pancreatitis. Followed by other meta-analysis that was published as well, looking into around 200 patients for chronic pancreatitis, for chronic pancreatitis and 5 for pancreatic cancer. Again, pain relief in pancreatic cancer was superior. It was 72% compared to 51% in patients with chronic pancreatitis. So in general, if we're talking, I think we have good results for pain relief in patients with pancreatic cancer. For chronic pancreatitis, we have reasonable results, but it's still debatable, and maybe improving the injectate or the technique can give us a better results. Now, comparing the celiac plexus neurolysis to the celiac ganglia neurolysis, as you can see, the most important factor for successful celiac ganglia neurolysis is if you can have it seen in the endoscopic ultrasound screen. So if it's visible, you have 15-fold more likely to respond with an odds ratio of 15. Looking into the RCT data, the positive response for EUS CGN group was 73%. For the CPN group was 45%, and the complete response was higher as well if you target the ganglia of about 50% compared to the CPN. So probably CGN can give you more good results but yet we need a larger retrospective cohort studies to look into this and to prove that in a more sophisticated matter. Now, complications that can be related are all related to the blockage of the sympathetic afferent activity. So those are the common ones, and it's very important to discuss this with the patients before you do the procedure. They can have transient pain exacerbation after the procedure. They can have hypotension. We usually keep our patients for 2 hours after the procedure monitored to make sure that they don't have any hypotension. They can have diarrhea in around 1/4 of the patient and inebriation in around 1 out of 10 of those patients. Now, this is the summary that summarizes all the complications. The complications which are common are common. There are a few cases that have celiac arteries thrombosis, and maybe this is related because of the injectate around or really close to the celiac artery. Can give you probably, one patient have to be reported to have multiple organ infarction. Necrosis of the stomach have been reported, infarction of the liver, and ischemia of both organs. So it's very important during consenting those patients to mention a rare complication that have been reported in the literature. So to conclude, I'd say EUS CPN have been proven to be safe, effective method for reducing pain in originating from the upper abdominal organs, especially pancreatic cancer pain. And we know that bilateral EUS CPN may be more effective than central EUS CPN, although central CPN is easier and possibly safer. And EUS CGN may provide better pain relief than central EUS CPN without increasing the risk of the complication. You're all invited to join